Dr. Theodore Schwartz, welcome to Neurosurgery Tales. It's my pleasure to dive with you into conversation of the themes of the book that you wrote, The Gray Matters, and it's really a pleasure for me. Thank you for joining us.
Well, thanks so much for having me on your podcast. Happy to be here.
I'd love to ask you what inspired you to write this book. Were there a specific moment that led you to document the history and evolution of neurosurgery?
So I felt that I had a story to tell because I don't really think that the general public knows what it is that we do as brain surgeons on a daily basis, what our lives are like, how we impact the lives of the other people around us, how our field has impacted cultural history and society in general, how far we've come, where we're going. So I wanted to take the time to document all of that in a way that I thought would be interesting to people who are not brain surgeons, who could read it and enjoy it as a book and as a story that would take them through sort of, our field, not just the history, but what it's like to do what we do.
I don't think there is a book that explores the history of neurosurgery from the time of Harvey Cushing till nowadays. I think this is the first one.
Yeah, there are some great books that are out there written by neurosurgeons who are wonderful writers, and I've read them all, and I really enjoy them. And most of them are memoirs talking about their cases, and they talk a little bit about their lives. But I didn't think there was a book quite like this one, that sort of says to the public, hey, this is where we came from, this is where we're going in the future. And I tried to do some memoir writing only because I think it draws a reader in when you talk about yourself and your own feelings and your own emotions and your own experiences. And so I did think that was necessary, so it wasn't too dry. I didn't really want it to be a history of neurosurgery, like a historical textbook. I really wanted it to be a story that people could pick up and read and enjoy and have trouble putting down, because you wanted to know what was going to happen next.
And writing a book like this, it's while still having a remaining career in practice, it's no small feat. How did you manage the both writing and the surgery practice?
I think that as a academic doctor, an academic surgeon, you become very good at multitasking and compartmentalizing your day. So I write a lot of papers. I do a lot of research. I run a basic science lab. I write a lot of clinical articles. I'm constantly mentoring students. And you have to figure out how to make time for those things as well, and balancing those things with your clinical practice. So it was just another activity that I did during my day, whether it was between operations while OR rooms were turning over or ENT surgeons were opening for me. Or on the weekends, I'd wake up, early in the morning on Saturday morning or Sunday morning. And we're used to waking up early as surgeons, and the rest of the world wakes up a little later on the weekend. So it gives us a bunch of free time to pursue hobbies and activities. And so I wrote the book. A lot of it was over the winter. I do play golf. So when I wasn't playing golf, when the weather was nice, we have seasons in the Northeast. So when there was snow on the ground and I had nothing to do, I would sit down at my computer and write.
That's wonderful. And writing a book like this involves the technical knowledge and deep reflection. How did this process of writing help you reflect on your own philosophy in neurosurgery?
Part of it is also research, right? There also was this element of curiosity. So when I would come to a different topic, I would try to approach that topic from a variety of different perspectives. So, for example, if I'm writing about aneurysms, and I don't do aneurysm surgery right now, so I had to review the history of who clipped the first aneurysm and why was that done. I had to tell stories of people who had aneurysms clipped that we know about, like Joe Biden. If I wanted to talk about interventional neuroradiology, Amelia Clark is an actress who had her aneurysms embolized, so I could tell their stories, which the general public would be interested in. But then I could think back on my own experience. What was it like when I first clipped an aneurysm? How did it feel to me? And when I was first in attending and doing it on my own, how was that experience? How was it welcomed or not welcomed, as the case may be, by the existing aneurysm surgeon at the program where I was operating on and tell that story as well. So I think by coming at one topic from a variety of different perspectives, it enriches your description of that particular disease. And I organized the book based on diseases, and a lot of people in the public are like, I don't understand how you organize this book. Like it's not chronological. It doesn't make any sense to me. And I said, yeah, but from our perspective, it makes sense because I'm dealing with diseases and I'm categorizing and chronicling, different diseases the way we think about them as neurosurgeons. So it's not about my life, it's not about history, it's more disease specific. And within each of those diseases, there will be logic to the chapter. But from chapter to chapter, it will jump from disease to disease. And I also felt like I was trying to take the reader through their own residency in a way by taking you from head trauma to brain tumors to aneurysms and sort of moving through neurosurgery, getting to the more esoteric topics like brain-computer interfaces and epilepsy surgery.
And your book traces the evolution of neurosurgery from the era of Harvey Cushing to the present day. What do you think are the most transformative advancements that have occurred in the field?
There have been a few revolutions. The first, of course, was Cushing's revolution, which really took neurosurgery from an operation that had a 50% mortality down to an 8% mortality. So that was critical because if what we do is not safe, then we shouldn't be doing it. And I do write a bit about Walter Dandy, but Dandy really just made it more effective. He was more of a technical wizard who could do it more quickly, and obviously did accomplish quite a bit. But the next great revolution, I think, was really Yashergill, who introduced the microscope into neurosurgery. And the concept of seeing the anatomy at a microscopic level and realizing how much more we could do with microscopic neurosurgery. And then after that really is the computer revolution, which we're in the midst of right now. And that takes us from stereotaxis all the way to brain-computer interfaces, all has to do with our ability to interface with mathematics and computers and, manipulate images in 3 dimensions. And so I think neurosurgery has benefited from really all the technical revolutions that occur in the rest of the world. I mean, Cushing's revolution really was antisepsis and anesthesia, things that were going on in general surgery that he adopted to neurosurgery. So same thing with the microscope. The microscope was really mostly used by the otologists for doing ear surgery before the neurosurgeons adapted it to neurosurgery. The endoscope could be another revolution, but I think it's not as great a revolution as was the microscope, the safety revolution, and of course, the computer.
As someone who studied the history of neurosurgery, how do you reconcile the traditional techniques with teaching, with the need to innovate and adapt to new technology? Where do you see the line between preserving the past and walking into the future?
I try to chronicle many different revolutions in neurosurgery that have occurred. And every time something happened that changed the way we practice neurosurgery, the existing senior neurosurgeons were very reluctant to adapt it and very resistant. So you can go back to even the evolution of the microscope. Yashergill had a hard time bringing the microscope into neurosurgery, and when he started his career, the senior neurosurgeon in Zurich wouldn't let him do much more than just angiograms. So he really tried to keep Yashergill down, but couldn't because the microscope clearly was a revolution, and Yashergill was doing things that we all needed to be doing. The same is true in the history of movement disorder. I chronicle the work of Irving Cooper, who really discovered accidentally that you can make a lesion in the brain somewhere and alleviate someone's tremor without paralyzing their arm. And at the time, Paul Busey, who is the senior tremor, Parkinson's, movement disorder surgeon in the world and in the country, really thought that was impossible. And he tried to convince the world that what Irving Cooper was doing was nonsense, but he was wrong. And so the same is true of the endoscope. When I started doing endoscopic surgery, a lot of the people in my own practice and around the world thought those of us who were using the endoscope were doing something that shouldn't be done, and that going up through the nose into the brain would lead to brain abscesses and infections, and everybody we did it on They had tried it in the past, it didn't work, and so it couldn't be done. But the truth was, with modern antibiotics and with making larger bone openings and learning how to close them and using endoscopes instead of microscopes, we now realize, that really is a better way to do several operations to take out tumors. And the same is true of stereotactic surgery, interventional radiology. The aneurysm surgeons were very reluctant to accept that you could treat an aneurysm by basically taking a needle and puncturing the skin and threading a wire up through a blood vessel. That met with enormous resistance when that was first introduced. And the same is true of radiosurgery for treatments like trigeminal neuralgia or acoustic neuromas, where the surgeons who were doing them open didn't think that that was really a viable way to treat that type of disease. So every time there's a revolution in neurosurgery, it meets with great resistance from the powers that be. And the problem is that the younger neurosurgeons are very deferential to their teachers, because when you go into neurosurgery, it's really an apprenticeship. And in apprenticeship, really, there's an apprentice and a master, and the master really knows everything, and the apprentice knows nothing. And you have to rely on your teacher to teach you how to do neurosurgery and to show you what to do. And you don't know how to do it, and obviously, if you were to go off on your own, it'd be very dangerous. So you're very deferential to what they do. They've seen all the complications before, and it's very hard for us to innovate and to say to the people who trained us, hey, you know what, I know a better way to do this. But I think that great teachers now look for that, and great teachers now encourage our pupils and our students to do things that are better than the way we do them. And I go into every operation not thinking that I'm doing it the best way it could be done, but I'm always looking for ways to improve what I do. And if one of my residents or fellows says to me, hey, why don't we try this, or why don't you do it this way, I don't just brush them off, but I really think about it. And I think about, does that make sense? Maybe I should be doing it a different way. I'll often ask fellows who have trained at other programs to teach me what they learned at their other programs, that maybe I can pick up some tricks from other professors at other universities that I just haven't been exposed to, so I can be a better neurosurgeon. And a lot of the progress we make is from collaborating with surgeons from other fields. And it's very important to keep your eyes open and see what people are doing in the OR next to you, because we're very siloed in what we do, to try to figure out how to move the field forward. But the only way to do that is to know that you're not perfect. You need to get better and be willing to change what you do to improve our field.
And you mentioned the skepticism from the mentors and like older generation of neurosurgeons regarding endoscopic neurosurgery. How do you personally navigate that resistance?
I think perseverance and knowing that what you're doing is the right thing. So you have to be very careful in the same way that Cushing had to make sure that neurosurgery was safe, to convince the world that there should be a field of neurosurgery, that he wasn't just killing patients left and right. It was important for the endoscopic skull-base surgeons to make sure their surgeries went well, and the results were excellent. So we had to be very, very careful and meticulous not to get vascular injuries. And then we had to figure out how to close the skull base, which was very challenging. And at our program at Cornell, I did all the skull base closures mainly because I knew that if I couldn't get as low a CSF leak rate as possible, that my colleagues would say, hey, you really shouldn't be doing these operations. This is ridiculous. The CSF leak rate is too high. And so that really became the focus, was in making the surgeries safe. And once we made them safe, then we could prove efficacy in head-to-head comparisons with transcranial surgeries. It was very challenging, though, to be performing operations and knowing that senior, more powerful surgeons were somewhat skeptical, and understandably so. I don't criticize them for feeling that way. I would feel the same way if someone were doing something different than I did it. I would say, hey, you got to prove to me that this is better. I'm not just going to take your word for it. I need some evidence. I need some data. So I think it was certainly justified to be skeptical. But of course, once the data started coming in and once it logically made sense, you have to, the field ultimately will move forward if it is a better way to do things, and people saw that and realized it. But it takes, inner fortitude and knowing that what you're doing is right, and just sticking to your guns and not being a wilting flower and caving to pressure political pressure, which is different than, evidence-based scientific pressure. If the results were bad, we should abandon it. But it wasn't that the results were bad. It was just that politically more powerful senior people were saying, hey, you shouldn't do this, because basically we were stealing cases from them, and they didn't know how to do those techniques. But that's obviously not the right reason to stop doing something, if the data is there supporting it.
And you wrote extensively about history of neurosurgery in the book, and it was wonderful. Was wondering who was your inspiration in the field?
Well, so for writers, I just quickly, the first book I loved in neurosurgery was When the Air Hits Your Brain by Frank Vertosik. I read that book, when I was a medical student. I thought that was a wonderful book written. Jay Wellens recently wrote a book that's fantastic. Henry Marsh, his books are incredible. Paul Kalanick's writing is beautiful. Ben Carson's Gifted Hands also inspired me when I was younger. There's a book about Peter Giannetta working in a very small place. I read that when I was a medical student. There's a book about the Neurological Institute that hasn't been published in a long time called Neuro, which I think was also a fun book to read. So there's been a lot of books written by neurosurgeons or about neurosurgery that are excellent, that I've really enjoyed. Dr. Q is another inspirational story, of course. But in terms of historical figures, there's two that really speak to me the greatest. So one, of course, is Wilder Penfield. I was an epilepsy surgeon. My passion to go into neurosurgery was for epilepsy, and I worked with George Ogerman, who did a lot of awake language mapping during his operations. And to me, the most exciting thing to do was to have a patient in the operating room awake, to put electrodes in their brain, and have them do psychological cognitive tasks and try to figure out how the brain works using the access that we alone have as neurosurgeons to sample and probe the brain. And Wilder Penfield really was the neurosurgeon who started doing that and really set the bar very high for understanding the brain as a neurosurgeon. So he was a big inspiration, and his legacy is a big inspiration. And then William Van Wagenen is another guy whose name kept coming up in my career. He invented and developed the corpus callosotomy, a treatment for epilepsy, which led to the split brain experiments that really allowed us to understand how the left and right brain differ in ways that we didn't fully understand before, just by presenting information to intact brains on the left and right side. That the ability to split them and study them was really a remarkable revolution in our understanding of human brain function. And there's a fellowship named after Van Wagenen. He gave money to American neurosurgeons can get some money after their residency to train abroad. And I won the Van Wagenen Fellowship and was lucky enough to go to Munich, Germany, and do epilepsy work. And that inspired my research career. So I owe him a debt of gratitude for that as well.
In the book, you included stories and cases of real patients, celebrities, athletes. What impact do you think sharing these stories has on public understanding of neurosurgery?
I really wanted to convey to the public the way that neurosurgeons have impacted our society. And so one way to do that was to tell the stories of public figures who've had brain surgery and whose lives have been touched by neurosurgeons. Of course, by presenting stories of celebrities and politicians and sports figures, the general public would be interested in those stories, right? So I'm also trying to get people to read the book because they want to know, what happened to Joe Biden, or what happened to Amelia Clark or Michael J. Fox and his surgery, or why did Natasha Richardson fall down and die after she hit her head? Because those stories scare the public and they want to understand them. So those celebrity stories function in two ways. One is to draw the reader in, to give me a launching board to talk about a particular topic that they'll be interested in following. And then, of course, to show how neurosurgery touches the world and touches people's lives as it touched these people's lives. So it was just a tool to use. It was fun to research. All the information is available online, so there was no HIPAA violations, which I was worried about. I didn't have to speak to anybody. I read a bunch of their biographies or their accounts or articles written about them that interviewed them about what they went through. So I had that to draw from as my history, and then I could take off from there.
Also, the book Gray Matters not only provides technical skills into neurosurgery, but also glimpse into your personal experiences. How do you decide what elements to include in the book from your life?
So I do get very personal. I have taken care of both my parents, for example, had strokes and had neurological illnesses. My father had a Broca's aphasia that I had to diagnose at the time by wheeling him myself to CAT scan in another hospital where I didn't have any privileges. And I tell that story and what is it like to sit in the control room, as we've all done, as a resident or as a neurosurgeon looking at our own patients. Brain images come up slice after slice, and you see the measure of your success or your failure as a neurosurgeon as you look at your images. But what if those images coming up are your parents, your loved one, and you're discovering something in the brain that you wished you didn't see, but you clearly see. So I tell that story, visualizing my father's stroke, as the images came up in front of me. And then my mother had a carotid endarterectomy after she had a TIA, and I tell her story, and she has a wonderful story. She's a Holocaust survivor, so I tell that story and talk about stress and how it contributes to vascular disease. But then talk about what it's like when you're operating, in one room and your mom's having surgery in the next room. And you go and examine her in the recovery room afterwards to see if she can still talk and see if she can still move, and just all the emotions that go through you in your brain as she's waking up from anesthesia. I also had the opportunity to take care of friends of mine in the community where I live who had subarachnoid hemorrhages, parents of friends of mine who came into the emergency room with strokes, and how those were treated. So there are obviously many more of those stories that I've experienced than are in the book, but I wanted to only include those stories that moved the narrative forward and moved the story, contributed to what I was trying to say in a meaningful way. And I think those stories are very important because, again, it's the humanity of what we do that comes across through those personal stories. If you just tell a dry history, it tends to be somewhat boring. The history of neurosurgery could be extremely boring if you just go from this person did this and this person did this. You don't realize all the lives that they touched with their discoveries, and what is it like to have someone's life saved and contribute to the saving of someone's life. So I wanted to get to the bottom of the emotion and the joy of contributing to taking care of other people. And also the psychological burden of having to take care of other people, and the rare times in those instances where things don't go well, and how that weighs on us. So all of that brings in, the emotion of what it is to do what us do. We're not just mechanical robots, brain surgeons. Yeah. We're not just playing classical music and doing fine, surgeries under a microscope. There's a lot of emotion in what we do, not only for ourselves, but in how we impact other people.
Neurosurgery is also about mentorship, and I was wondering how that shaped your career and what legacy do you want to leave for the next generation of neurosurgeons.
So I had some mentors along the way who inspired me. One was George Ogerman. I write about him. What it was like as a student to travel across the country and go to a foreign city and work with him and help him. And Dennis Spencer, where I did a fellowship. One of my biggest mentors actually was an ENT surgeon named Vijay Anand, who is not a neurosurgeon. And that's, I think, somewhat unusual to have a mentor that's not in your field. But I really owe a lot of my career to an ENT surgeon who really wanted to dive into doing endoscopic skull-base surgery before very few people in the world were doing it, and helped motivate me and support me, give me positive feedback and encouragement. Sometimes we don't always get the same positive feedback and encouragement from other neurosurgeons, because neurosurgeons tend to be very competitive. And we have to deal with competition from our peers and even from some of the more senior people, because we're our egos are built around how many cases we do and how busy we are, and we don't like to give those cases up. We don't like to admit that other people may be better at doing things than we are, which is why some chairmen have a hard time getting their faculty to subspecialize, because those people don't want to give up cases. So it was great for me to have someone in a different specialty, right? I wasn't competing with him. He was nothing but a collaborator with me. And we taught each other along the way how to do these operations. And he was just a wonderful, warm, loving, spirited, and is human being who I benefited immensely from having a relationship with. So he was a big mentor of mine. I try to mentor residents. I started a fellowship to try to help fellows learn how to do these operations and try to help get them jobs. I try to help our residents publish as many papers as they possibly can. I like to write, so I'm happy to edit their papers and give them ideas for how to write. And I meet with the residents one-on-one, once every 6 months, and just sort of talk with them about what they're working on and try to give them ideas to help their careers and help them think about what they're doing and why they're doing it. So I do think mentorship's important. And then I also have students who shadow me over the summer, which tend to be high school students or college students who might be interested in neurosurgery. And I go out of my way to welcome as many of them as I can into my operating room, because going into a field like neurosurgery is very daunting, and you really want to get a sense of what is it like to do this job before you think about doing it. So I'll often have 7 or 8 students who shadow me over the summer. And I also have a lab. So I have people I take in the lab who are interested in research, who want to build their resumes and learn what research is like. So I'm mentoring those students as well and trying to give them opportunities to build their CVs so that they can go on and have competitive applications in the next stages of their lives. And it's very rewarding when they, stay in touch with you and they contact you and they say, hey, this is where I am. This is where I am. This is what I did. Thank you very much for your support. That's a beautiful thing.
That's very generous of you. Patients' outcome can be unpredictable. How do you cope with the emotional weight of difficult outcomes? What strategies do you use to maintain well-being and focus with the next surgeries and cases?
So, one of the most difficult things about brain surgery that is not really talked about is that there is inherent in what we do, particularly if you're doing complex brain surgery, there are complications that will occur in everybody's hands, and we will fail from time to time. And when we fail, we can hurt people significantly because what we do is so critical and important, and the areas that we're working in are so delicate. And it is psychologically very challenging to handle the burden of knowing that you've damaged someone else's life in some way, even though you did your best to try to help them, and they were battling a disease that obviously the outcome of the disease would also have been devastating if not treated. So you have to balance the risks of what you do versus the risks of not doing anything. But we have to go on, and we have to treat the next patient and compartmentalize the pain that we've been through. At the same time, as much as we have to erect emotional armor to compartmentalize the bad outcomes, to focus on the next patient, we then have to go back to that patient and round on that patient and talk to that patient's family for days, weeks, and sometimes even months if they're in the hospital with a complication that needs to be managed. And what's very difficult and critically important is to not ignore those patients and not block them off. It's very hard to round on a patient who had a bad outcome. It's very hard to talk to a family that you've disappointed and is disappointed in you. But those are the patients that you have to see even more frequently, and you have to face it. And then you have to take down that emotional armor that you erect to do the operation. And you have to have emotional flexibility to re-erect the humanity and sensitivity and empathy. I have cried in the arms of some of my patients' families members when things did not go well, and have revealed the vulnerability, my own disappointment in myself, and my incredible deep sadness at the outcome when things didn't go well. And every time that I've really broken down and cried in front of a patient's family or a patient, they have done nothing but appreciate it because, they're obviously angry and upset, but they really want to know that you're not cavalier about it, that you know in your soul that this is another human being that is incredibly important and valuable to them, and that you care deeply about that person. Obviously, if things go well, it's just, you literally, it's like a hug and a thank you, and you move on, and it's the greatest high ever when you have a successful surgical outcome. And luckily, in modern neurosurgery, 98% of the time we have successful outcomes. So the highs and the joy far outweigh the lows, but those lows will come. They will be there, and they're always waiting for you, and you can never forget them because they're always waiting in the wings, and that's what drives you to be better and better and better. And that's what makes us go to bed early and not drink too much alcohol and exercise and, take care of ourselves, because the feeling of failure and disappointment when things go wrong is something that you never, ever want to feel again once it happens. And you will do everything in your power to avoid it, which is important that you feel that way, because that's what keeps us working at our best.
One of my favorite chapter was the one that you explored the theme of psychosurgery and the allegory of Pandora's skull. I think it's perfect. It can't be said better. So you explored the potential risk of psychosurgery, particularly the idea of controlling brain function and to influence mood and behavior. How do you reconcile the exciting possibilities of these advancements with the ethical dilemma they present in terms of consent, civil rights, and potential harm?
Those are great questions. There's a long history of psychosurgery, and we've already made the mistakes. They've been made in the past, so we know what not to do. When we first, the frontal lobotomy emerged in the 1950s, there was a lot of enthusiasm, but no regulation, and surgeons were doing it wantonly on patients, some of whom were helped, but many of whom were hurt by the operation because there was no informed consent. There were no IRBs back then. We now have even more power in our hands to alter personality and emotion and behavior with electrodes stimulating people's brains. And that technology will only get better and stronger and more powerful. If you believe that the brain and the mind are the same thing, and that all emotions and all desires and all our experiences come from the brain, then it stands to reason that if you manipulate the brain, you will be able to manipulate everything in human experience. And that has proven to be true. And there are examples of that that I give in the book. And so now that we have the ability to basically control another human being's emotions, behavior, desires, wants, fears, who gets to do that? In what scenarios could that be done? Should that be done? Those things have to be very, very carefully considered, which is why right now we only do those treatments to treat diseases, things that we think are pathological, people whose lives are damaged by the fact that they have negative emotions constantly that they cannot control, whether it's depression or obsessive compulsive disorder or someday schizophrenia. But the problem is when it becomes politicized. When you say, well, these prisoners, can't control their aggression, therefore we should put electrodes in their brain to pacify them, which has been done and theorized should be done. How do you define what the appropriate amount of aggression is? How do you figure out which patients will benefit from this potential treatment versus be harmed by this treatment? I think those decisions are very difficult for us to make at the moment because we don't fully understand. Our society has not agreed on, appropriate levels of aggression. In a football player on a football field versus, walking down the street. So I think before we move into those arenas, we need to have guardrails and safeguards. But at the moment, it's being used mostly at academic institutions under IRB regulations to treat pathologic diseases where there are committees of people agreeing, psychiatrists, neurologists, neurosurgeons, that this individual has a disease, that they want it treated, that informed consent is signed. And I think now we have those barriers and guardrails erected. The field can move forward because it will move forward delicately and safely, step by step, to move us forward in the right direction. But none of those guardrails were up in the past, and that's why so many mistakes were made.
And lastly, if you could have dinner with any individual from the past or present, from neurosurgery or outside neurosurgical field, who would it be and what would you talk about?
Probably Wilder Penfield. I think it would be fun to have dinner with him and talk to him about some of the patients, some of the experiences he had stimulating the brain, and what he learned about the human brain, and just sort of theorize about him, about how the brain is organized and how consciousness is created, and he stimulated the brain and elicited all of these experiential phenomena that people would relive moments in their lives, and I would love to talk to him about that.
Mm-hmm.
I think that would be really fun.
Doctor, thank you so much for being here and for your time, for sharing your reflections, and thank you.
It's been a pleasure. Thanks for having me.